Welcome to NIKAM's Rapid EKG Interpretation. I am Dr. NIK NIKAM, and I would suggest you grab a notepad and a pencil so that we can learn something about each electrocardiogram we're going to read. And there are probably a little less than 100 EKGs here. We are going to read it in a rapid session, so get ready and let's begin. Now here's an electrocardiogram which looks like irregular. We don't see definite P waves. The underlying atrial rhythm appears to be atrial fibrillation, and there's good R wave progression in the inferior leads, and in the anterior leads there is a slight decrease in R wave progression. This may suggest old intraseptal myocardial infarction. In addition, there are non-specific STT changes noted throughout the electrocardiogram. So this is an abnormal electrocardiogram with the atrial fibrillation, loss of R waves anteriorly, which may suggest anterior myocardial infarction, and non-specific STT changes. All right, next electrocardiogram. Here's another electrocardiogram which appears to be similar to the one we saw before. It could be from the same patient. There appears to be atrial fibrillation, which is the underlying rhythm. Again, there is loss of R waves anteriorly, but a little less pronounced compared to the previous one, and along with the STT changes that we saw similarly in the previous electrocardiogram. So this is atrial fibrillation with the non-specific STT changes and loss of R waves anteriorly. Here is another electrocardiogram. Immediately you can see the RR interval is short. The rate is approximately 116 per minute. That means there is a P wave and a QRS complex. So what we are looking here is a sinus tachycardia at a rate of 116, and along with that, there are some non-specific T wave changes. The T waves are flat throughout the electrocardiogram. So we have a sinus tachycardia at a rate of 116 with the non-specific STT changes. Other than that, the QRS complexes look all right for practical purposes. Again, there is loss of R wave in V1 and V2, and this may be related to lead position, and this is something which has to be confirmed by a repeat electrocardiogram. Okay, here's another electrocardiogram which has some interesting finding. As we can see, the rhythm is a sinus because there's a P wave before each QRS complex. Then we have a RSR prime in V1, V2, and that is suggestive of right bundle branch block. Again, we see slurred S waves in the lateral, anterior and lateral leads. Along with that, there is also a significant negative deflection in lead 2, 3 and ABF that suggests a left axis deviation, left anterior hemiblock, and the PR interval is okay. So we have a bifascicular block characterized by left anterior hemiblock and right bundle branch block, along with some non-specific STT changes. Here is a different electrocardiogram which has a lot of interesting findings. First thing, this is sinus rhythm. Number two, you see increased voltage broadly throughout the electrocardiogram. The negative deflection in the atrial negative deflection is occupying more than one box, so this is suggestive of a left atrial enlargement. There is increased voltage in the anterior and lateral leads, suggestive of a left ventricular hypertrophy. What I would like you to do is go to your textbook and write down the criteria for left ventricular hypertrophy. Enlargement of the left atrium is given 3 points. Increased voltage gets 3 points. Symmetrically inverted T waves get 3 points. So there are multiple points to suggest definite left ventricular hypertrophy in this particular patient. Along with that, do we see any evidence for an infarction? We don't see any evidence for an infarction or any ectopic beats. So this is a very interesting electrocardiogram, a classic finding of left ventricular hypertrophy with the left atrial enlargement, increased left ventricular voltage, along with the secondary repolarization changes due to left ventricular hypertrophy. And if you were to do an echocardiogram in this patient, you are going to see left ventricular hypertrophy, possibly diastolic dysfunction, left atrial enlargement, and all these findings will be confirmed by echocardiography. Okay, here's another electrocardiogram. Again, we have a rapid rate, 101. So this is a sinus tachycardia because we have a P wave followed by QRS in each one of these complexes. And along with that, there's good R wave progression in the inferior leads, and in the anterior leads, they look okay. There are some non-specific STT changes. In the previous reading, I mentioned that you need to look at electrocardiogram not as individual 12 leads, but as groups of leads. 2, 3 ABS, they represent the inferior wall. Lead 1 to V1 to V4, they represent the anteroseptal region. V5, V6 represent the lateral wall or the circumflex marginal branches. Lead 1 and ABL represent the high anterior wall or the diagonal branch of the left anterior descending trunk. So this represents the left anterior descending artery. So that's how you correlate, because you see changes in groups of leads that are supplied by a particular artery or a branch of an artery. Okay, the interpretation here is a sinus tachycardia with some non-specific STT changes. Go on to the next one. Again, we have a sinus tachycardia with non-specific STT changes, but no evidence of recent or old myocardial infarctions. Okay, this is a nice electrocardiogram here. The rate is approximately 60, so basically sinus bradycardia. This is sinus rhythm, but look at here, there's loss of airways anteriorly. All the way up to V5, there's poor airway progression. So this may suggest several things. One, it may represent anterior myocardial infarction. It may also represent lead misplacement. It may represent a chronic obstructive pulmonary disease, or it could be due to pericardial effusion or pleural effusion, which is keeping the heart away from the chest wall, thus making the presence of loss of airways. That's why a clinical correlation is always indicated. EKG is just representation of what these leads see when we record the electrocardiogram. But nonetheless, they do point to so many different other abnormalities. Like in this case, why is this patient having loss of airways almost anterolaterally? This could be if you place the leads in a high up position, then all the electrical activity is moving away from the electrode. As a result, you're going to get a QS complex. Maybe repeat this electrocardiogram by putting the leads at least 1 or 2 spaces below the nipple or the fifth intercostal space, and see if you can get better airway progression. If patient has chronic obstructive pulmonary disease because of emphysema, there may be a lack of airway progression in the anterior leads. Also, the T waves are okay, but the ST segment is slightly abnormal. So this is a sinus rhythm with the loss of airways anterolaterally, along with okay, this is a sinus rhythm with the baseline artifacts. This is called baseline artifact. This is not atrial fibrillation or atrial flutter, because these cycles are almost like 600. This may be what is called the 60 cycle baseline artifact. Sometimes it's hard to find out what the rhythm is, but if you look at here, we have a P, QRS, P, QRS, P, QRS. So this is sinus rhythm with the baseline artifact and non-specific T wave changes. The T waves need to be really nice, smooth, rounded, and peaking in all the leads except for AB, R, and lead 3. If it is not, then we are looking at non-specific T wave changes. So those are some of the minor findings in this electrocardiogram. Okay, we have a sinus rhythm with the left atrial enlargement and some increased voltage in the lateral chest leads, along with some STT changes, possibly suggestive of mild left ventricular hypertrophy. There is a tendency towards left axis deviation, but the criteria is not adequate enough to call it left axis deviation. But nonetheless, this is an abnormal electrocardiogram with left atrial enlargement, and STT changes is suggestive of some mild degree of ischemia in the lateral leads. Wow, look at this. The rate is 140 per minute here, and the STT segments are flat. And along with that, there is some left axis deviation, and we see some STT changes in the lateral leads. So this is atrial fibrillation with a rapid ventricular response, and also there is a Q in lead V2, which may suggest an old anteroseptal myocardial infarction. So we are looking at a patient with atrial fibrillation with possibly left axis deviation, possible old anteroseptal infarction with STT changes. Here we have a nice sinus rhythm, good airway progression in the inferior leads. The anterior leads, there is some lack of airway progression. Again, this may be related to lead positioning, and it is very important, especially if you are a technician, to make sure that if you see poor airway progression in the anterior leads, to place the leads at least 1 space below and repeat the electrocardiogram so you can see a difference. If you see a difference, that means this lack of airway progression may have been related to the lead position. Especially this happens when you place the leads way too high, because if all the leads are above the heart level, the electrical impulse is moving away from the lead, and that gives you the negative deflections in the anterior and perhaps even the lateral chest leads. Along with that, we have some non-specific T wave changes. So this is a sinus rhythm with lack of R wave progression in the anterior leads, along with some non-specific T wave changes. Okay, here again we have a baseline artifact. Before we had baseline 60 cycle artifact. Here the baseline itself is wavy, but nonetheless this is a sinus rhythm. You can see some P waves here, along with some non-specific STT changes. And there's also a non-diagnostic Q in 2, 3, and AVF. The Q waves have to be at least one full box and at least 25% of the depth of the R waves in order for them to qualify as pathological Q waves. So these are non-diagnostic Q waves. They do not represent inferior myocardial infarction. We have a sinus rhythm here, some non-specific ST changes. There may be some ST depression in the lateral leads and also in the inferior leads. So this is an abnormal electrocardiogram. Along with that, I think there is some evidence for left atrial enlargement, loss of R wave progression in the anterior leads. So we have a sinus rhythm with left atrial enlargement, possible old anteroseptal myocardial infarction, along with some subendocardial ischemia, which is sort of diffuse, involving the inferolateral chest leads. So there are a lot of findings in this electrocardiogram. The moment you look at the electrocardiogram, it should look to you not as individual leads, but like a picture, just like as you see a picture of a human being on a magazine. So that's how you identify, oh, that is Rebecca, or that is Kim, or whoever it is. And this is a patient with anterior infarction with subendocardial ischemia. That's how you immediately jump to the conclusion, and you do that by practice, by paying attention to all of the minute details that make up the 12-lead electrocardiogram. Again, going back, this is sinus rhythm with left atrial enlargement, old anteroseptal myocardial infarction, and subendocardial ischemia in the inferolateral chest leads. All right, this is a sinus rhythm. Again, loss of R waves anteriorly, and also there is negative T wave in lead V1 and V2, along with some increased voltage in the anterior leads. If you have increased voltage in the lateral chest leads, the negative deflection sometimes may be related to left ventricular hypertrophy. But if you don't have any other criteria to suggest STT changes or left atrial enlargement or atrial fibrillation, anything like that, then you begin to wonder about, does this really represent an anterior infarct? There's no way to confirm that unless we do an echocardiogram or a myocardial perfusion studies to see if there was a previous myocardial infarction and a myocardial scar. But nonetheless, this is a sinus bradycardia because the rate is less than 60. Less than 60 is bradycardia, 60 to 100 is sinus rhythm, above 100 is sinus tachycardia, above 160, 170 is paroxysmal supraventricular tachycardia. Of course, if you exercise, your heart rate can go up to 180 depending upon your age. So that's about the division of various types of terminology that we use based on the heart rate alone. So this is sinus bradycardia with possible old anterior myocardial infarction. But other than that, we don't see anything else of significance. Okay, here we have what appears to be a varying RR interval. The RR intervals, but here we see good P waves. That's why I said you need to look for P waves in multiple leads to make sure that you're dealing with either sinus rhythm or atrial fibrillation. So this is sinus rhythm, and we have an RSR prime, so we have an incomplete right bundle branch block. For it to be called a complete right bundle branch block, it has to have at least 0.12 milliseconds, otherwise 3 boxes. So we have a sinus tachycardia with right bundle branch block and perhaps non-diagnostic Q waves inferiorly. And those are some of the main findings we see here. Sinus rhythm, good R wave progression in the anterior leads. The lateral leads are okay, except for some T wave changes. So sinus rhythm with some non-specific T wave changes. Sinus rhythm, incomplete right bundle branch block, low voltage. Look at the voltage here. It's less than 5 millimeters across the board, along with some STT changes. So we have sinus rhythm with low voltage and non-specific STT changes, plus incomplete right bundle branch block. It's also loss of R waves in 3 and ABF, this may suggest an old inferior infarction in addition. So this is an abnormal electrocardiogram. Okay, we have a sinus tachycardia here. The rate is about 112 and there is R wave progression which is adequate, but we have some non-specific T wave changes. Again, we have sinus rhythm here because we can see good P waves. The rate is around 86 and there is Q wave only in lead 3. It is not uncommon to see isolated Q waves in lead 3 unless it is substantiated in lead 2 and ABF. We don't call that as a pathological Q wave. So this is non-diagnostic Q wave in lead 3. And we have good R wave progression, but we have non-specific STT changes. So this is sinus rhythm with the non-specific STT changes in the anterolateral leads. Again, right bundle branch block. The moment you look at lead 1, you should be able to say this is right bundle branch block. I don't even need to look at this classic rabbit ear or RSR prime and look at it involves more than 3 blocks. So this is a definite complete right bundle branch block. So that's what we are dealing with. Along with that, we have some non-specific STT changes and non-diagnostic Q waves in the inferior leads. The lateral wall looks okay. Atrial, okay, we have sinus rhythm, but the RR intervals are varying. So you wonder about, is this atrial fibrillation with sinus rhythm with atrial ectopic beats, or are we dealing with a Wenckebach, something like that. But it's very hard. Unless we have a long rhythm strip, we may not be able to discern the underlying varying changes in the RR intervals. But with the strip that we have, I can say this is a sinus rhythm with PACs. And along with that, we have non-specific STT changes in the inferior leads, loss of R wave progression in the anterior leads, along with STT changes in the lateral leads. So what is our final interpretation? Sinus rhythm with premature atrial complexes, old anteroseptal myocardial infarction, along with the non-specific STT changes across the board. We have a normal sinus rhythm with the non-specific STT changes in the anterior leads and also lead ABL. Otherwise, nothing significant here. All right, we have a sinus rhythm, good R wave progression in the inferior leads, non-diagnostic Q waves in the inferior leads. Anteriorly, we good R wave progression, laterally looks okay. So this is a normal electrocardiogram. Sinus rhythm, good R wave progression here. STT segments are normal. Anteriorly also looks okay. So this is another example of a normal electrocardiogram. Again, we have sinus rhythm, non-specific STT changes. Anteriorly, we have a QS complex in V1, which is a normal variation, but is good R wave progression in 2 and 3, V2 and V3, and laterally looks okay. So basically, non-specific T wave changes. Okay, sinus rhythm with left axis deviation. There are Q waves in the inferior lead. So this may suggest inferior myocardial infarction. Similarly, this loss of R waves in the anterior leads from V1 to V5. So you wonder if this patient had anterior myocardial infarction. There's definite evidence of inferior myocardial infarction, and you wonder if there is anterior myocardial infarction because of lack of R wave progression. Again, this has to be confirmed by proper lead placement and by echocardiography, which will give you a lot more information about wall motion, left ventricular size, left atrial size, and all these things. Of course, there is left atrial enlargement as the negative deflection involves more than one complete box. So there are a lot of abnormal findings in this. This will also make me suspicious that maybe some increased left atrial pressure because of left atrial enlargement and an old inferior infarction. This is a patient with coronary artery disease, most likely with left atrial enlargement, and perhaps maybe old anteroseptal myocardial infarction. Now here we have a sinus rhythm, left atrial enlargement, left ventricular hypertrophy with non-specific STT changes. This ST depression is suggestive of left ventricular subendocardial ischemia. If it is associated with positive cardiac enzymes, it is called non-subendocardial infarction. If the enzymes are normal, this is considered to represent subendocardial ischemia. So always remember, ST depression means subendocardial ischemia. So we have a significant voltage criteria for left ventricular hypertrophy. We have left atrial enlargement, we have non-specific STT changes, or STT changes is suggestive of a subendocardial ischemia. So there is enough evidence for left ventricular hypertrophy, but there's not any evidence for a clear-cut infarction, even though there is negative deflections in the anterior leads, and they may be related to left ventricular hypertrophy. As I mentioned earlier, if you have significant left ventricular hypertrophy, you're going to see significant QS complexes in the anterior leads, but they usually have an initial R wave, which suggests that there is no evidence of a previous anterior myocardial infarction. Okay, we have a sinus rhythm here, left atrial enlargement, non-specific T wave changes, and also non-diagnostic. You have an initial R wave here, so they can be called Q waves, but we have negative deflection, but doesn't meet the criteria for left axis deviation. Okay, here we have a sinus rhythm, non-specific T wave changes, non-diagnostic Q waves in the inferior leads, basically non-specific STT changes, again loss of R waves anteriorly. There may be suggestion of a left atrial enlargement here. So those are some of the findings. Okay, low voltage in the limb leads and tall R waves actually in the anterior leads with non-specific STT changes both inferiorly and also anterolaterally. So this is an abnormal electrocardiogram with low voltage, non-specific STT changes, diffuse non-specific STT changes. Okay, here we see some pacemaker spikes. So this is happening before the QRS. This is happening before the QRS complex. So I would say this is atrial pacing with ventricular sensing and normal ventricular capture, except here the atrial, there is ventricular capture. But once you have a paced rhythm, it's very hard to say what the underlying rhythm or what the underlying pathology is based on just the electrocardiogram. But nonetheless, there is evidence of loss of R waves in the normally conducted beats. This may suggest a patient with a coronary artery disease with the old anteroseptal myocardial infarction, and perhaps a pacemaker related to some significant bradyarrhythmia, something like that. Okay, we have a sinus rhythm here, but there's an extra beat here. This is a premature atrial complex because there's a P wave preceding the QRS complex. Again, there are non-specific STT changes, but other than that, I don't see anything spectacular. Okay, we have a sinus rhythm, normal electrocardiogram. We have a sinus rhythm, non-specific STT changes here. The T wave is sort of biphasic, and also the T wave amplitude is decreased in the inferior leads. Okay, here we have left axis deviation, sinus rhythm, left axis deviation, incomplete right bundle branch block, loss of R waves anteriorly, along with some T wave changes. The T waves are sort of flat. So we have multiple findings, and this is suggestive of patients with coronary artery disease. Inferior wall looks okay, anterior wall, there's slight lack of progression, but otherwise everything else looks pretty normal here. Sinus rhythm, there's non-diagnostic Q waves in lead 1 and AVL. If you had a diagonal branch occlusion, you can end up with an anterior or high anterior infarction that is represented in lead 1 and AVL. There you would have a pathological Q wave which should measure at least 40 milliseconds or one complete box, and it should be at least 25% of the height of the R wave. So these are non-diagnostic Qs in 1 and AVL. Similarly, we have T wave inversion in the inferior leads, and throughout the anterolateral leads we have flat T waves. So this is an abnormal electrocardiogram with sinus rhythm and non-specific STT changes. Sinus rhythm, T wave changes, minor T wave changes. It also has a short PR interval. The PR interval is like 108 milliseconds. So that is, it should be at least 0.12 second, 120 milliseconds, but this is 108. So this is a short PR interval. So you have to pay attention to the PR interval here. Okay, we have sinus rhythm. Inferior leads look okay, anterior leads look all right, and the high anterior, and this is the anterior leads look okay, all right. Okay, we have sinus rhythm again, inferior leads, little T wave changes, anterior leads look okay, lateral leads T wave changes. So the most significant finding in this is non-specific T wave changes. Okay, right bundle branch block. I keep repeating this. Just look at lead one beat, and you can tell you what the story is. Here a terminal S wave which is slurred, that is right bundle branch block. There is increased voltage in lead 1 that may suggest some left ventricular hypertrophy problem. We'll come to that later on. We also have a left axis deviation, and we have a complete right bundle branch block along with poor R wave progression in the lateral chest leads, and this may be related to lead placement, especially if the leads are placed very high, because I see very good electrical voltage in 1 and ABL. I would expect to see similar voltages in the lateral leads unless this patient had a lateral myocardial infarction. But in the presence of a right bundle branch block, I would not see loss of R waves just based on right bundle branch block. There is also evidence of left atrial enlargement. So there are a lot of pathological findings in this particular electrocardiogram. One, there is increased voltage in 1 and AVL. That itself is suggestive of left ventricular hypertrophy, complete right bundle branch block, a left axis deviation, left anterior hemiblock that is equal to biphysical block, and there is a loss of R waves laterally, which needs to be confirmed by repeat lead placement, repeat EKG with proper lead placement, and by echocardiography. So there are a lot of things that we can interpret by just looking at one electrocardiogram. Okay, this is pretty rapid rate to sinus tachycardia at a rate of 120 per minute. The inferior leads look okay, the anterior leads look alright, the lateral leads reveal some T wave changes. But other than that, I don't see anything significant. So this is sinus tachycardia with some non-specific T wave changes. This is fascinating electrocardiogram. Here first of all, we have low voltage. Number 2, there are QS complexes in 2, 3 ABS that suggestive of old inferior infarction, left axis deviation, left anterior hemiblock, and here we have a negative deflection which is perhaps equivalent to one complete box. So we have left atrial enlargement. So we have left atrial enlargement. There is lack of R wave progression all across the chest leads. That is suggestive of poor R wave progression. What's going on with this patient? There are a lot of things going on with this patient. There's left atrial enlargement, low voltage. To me, this suggests a lot of things. When you see low voltage, you need to worry about hypothyroidism. You need to worry about pericardial effusion. You need to worry about large pleural effusion. You need to worry about emphysema. What are the other things that might help us to identify some of the things here? Left axis deviation, left anterior hemiblock, old inferior myocardial infarction. So this may be a patient with multiple infarcts, suggesting inferior myocardial infarction and perhaps lateral myocardial infarction, along with left atrial enlargement. Maybe a patient with cardiomyopathy. A whole bunch of things we should start worrying about, because these are all abnormal findings. So in summary, we have low voltage, sinus rhythm, left anterior hemiblock, left axis deviation, possible old inferior myocardial infarction, left atrial enlargement, poor R wave progression across the chest leads. Consider lead misplacement, repeat electrocardiogram, and also confirmed by echocardiography. Okay, again we have sinus tachycardia, rate of 140 per minute. Okay, non-specific T wave changes, but other than that, nothing really significant. Sinus rhythm, little baseline artifact, otherwise okay. Sinus rhythm, flat T waves, and inferiorly looks okay. Anteriorly, there's a loss of R wave progression, and the lateral leads look okay. So this could be related to lead misplacement or lead positioning, especially if it's a female patient. You always want to make sure that you place these leads below the breast so you can capture the positive deflections coming from the heart. Okay, we have a sinus rhythm, left axis deviation, left anterior hemiblock because of the negative deflection in 2, 3 ABF. There is an initial R wave, so you couldn't say for sure this represents inferior myocardial infarction. Anteriorly, we have right bundle branch block and poor R wave progression here in lead 3, 4, 5, 6. So you begin to wonder, we have a left axis deviation, right bundle branch block, loss of R waves anteriorly. Is this a patient with emphysema or something like that, which is causing the loss of lack of R wave progression? Is this related to lead placement? So these are some of the things you need to start thinking, and then examine the patient and see which criteria best fit what we find on the electrocardiogram. Electrocardiogram is just a representation of what we are seeing, and we need to use these findings in the context of a bedside examination of the patient along with other diagnostic tests like chest x-ray, echocardiogram, to really pinpoint how all the findings on the electrocardiogram fit with what is actually happening inside the patient's body. Okay, we have a sinus rhythm. Inferior leads, anterior leads look okay, inferior leads look okay, and anterior leads lack of R wave progression, RSR prime, incomplete right bundle branch block, the lateral chest leads okay. So we have a sinus rhythm with possible lack of R wave progression or an old enteroseptal myocardial infarction along with no other significant findings. Okay, here we have a sinus rhythm, left axis deviation, left anterior hemiblock, right bundle branch block, that is bifascicular block, along with the premature ventricular complexes and non-specific T wave changes. Actually, the electrocardiogram reads this as a first degree AB block. So we have a first degree AB block, we got a left anterior hemiblock and a right bundle branch block, and all of these put together may even suggest a possible trifascicular block. These are the patients who go on to have dizziness, weakness, or significant bradycardia, and at some time they may end up needing a pacemaker. Sinus rhythm, right bundle branch block, low voltage, non-specific STT changes. Sinus rhythm, lack of R wave progression in the anterior leads, non-specific T wave changes. Sinus rhythm, right bundle branch block, left anterior hemiblock, left axis deviation, and QS complexes, lack of R waves laterally. This may be related to, again, lead placement and a whole bunch of other things, or it may be even related to some degree of intraventricular conduction delay, because the QRS complex is more than 120 milliseconds or 3 boxes, as we can see here. Okay, sinus rhythm with perhaps a first degree AB block because it's a long PR interval. Then there is STT changes to suggest you have ischemia. There's lack of R waves anteriorly, and laterally there are some non-specific STT changes. So this is a sinus tachycardia with perhaps recent anterior myocardial infarction along with the non-specific STT changes. Left bundle branch block. All I need to look at lead 1, just one beat, and you can tell you why this is left bundle branch block. Well, let's look at it. We have seen multiple cases of right bundle branch block. When we go to AV1, we see a rabbit here, RSR prime, but this is the reverse of that. We see an RSR prime in lead 1, AVL, V4 to V6. A wide QRS in lead 1, AVL, V4 to V6 is suggestive of left bundle branch block. Again, look at the inferior leads. They also show wide QRS, positive deflection in leads 2, 3, AVF. And if you look carefully, you may also see a left atrial enlargement. So this is a classic case of a left bundle branch block. Sometimes you can see symmetrical T-wave inversion and ST depression that may suggest left ventricular hypertrophy, but nonetheless we have some non-specific STT changes along with the complete left bundle branch block. This is sinus tachycardia with inferior leads STT changes. Anterior leads look okay. So this is sinus tachycardia with the non-specific STT changes. Next one, sinus rhythm. Anterior. When I say anterior for 1 and AVL, that is representing the high anterior, which is supplied by the diagonal branch. Okay, inferior leads, nothing significant. Anterior leads look okay. Lateral leads okay. This is normal electrocardiogram. Okay, this is normal sinus rhythm. Anterior leads in anterior, inferior, and anterior and lateral. Okay, normal. Let's move right along. Sinus rhythm. T waves look okay. Anterior leads, we got some problem. There are some flat T waves anteriorly, and also laterally there are some flat T waves. So this is not a normal electrocardiogram. This is an electrocardiogram with non-specific T wave changes. So this electrocardiogram shows normal sinus rhythm. High anterior looks okay, and inferior leads are okay. Anterior leads look all right except for some minor T wave changes. Lateral leads look okay. So this is basically a normal electrocardiogram. Sinus rhythm. We see some artifacts here. You may think, oh, this is a pacemaker beat. No, not really. You must be able to substantiate it in other leads, and it's maybe just an artifact from what I can see. Anyway, this is high anterior looks okay, and inferior leads look all right. No left axis deviation. We have an RSR prime, which is probably non-diagnostic. If you want, you can put it, but at the same time, there is poor R wave progression in the chest leads. The voltage criteria is very, very low here. So you wonder, does this patient have a pleural effusion, pericardial effusion, or localized something inside the chest that may be making the leads from showing the electrical activity? Is this related to misplacement? If this is a female patient, if you put this way up above the breast level in the second space, you're going to get negative deflections in the anterolateral leads. So these are all the things that should come to your mind. Then you go back and look at the patient, look at the chest x-ray, look at the echocardiogram, and see, does this electrocardiogram fit? Does this patient have an anterolateral infarct, or is it just related to lead placement? That's how you have to begin to think and ascertain as to what is exactly happening inside the patient's body. That is more important than just looking at one particular test and say, okay, let's order more tests. Okay, we got a sinus rhythm here. High anterior looks okay. Inferior leads look all right. Anterior leads look all right. Non-specific T wave changes. They are not. Again, we have a RSR prime here, but more importantly, non-specific STT changes. You have a nice sinus rhythm. T waves are inverted in the inferior leads, at least in 3 and AVF, and anterior leads, they look all right. Lateral leads, we have some STT changes. So this is an abnormal electrocardiogram with a normal sinus rhythm with the infralateral STT changes. So you need to begin to wonder about possibility of a coronary artery disease, and that has to be substantiated with other tests like X-ray, echocardiogram, and perhaps nuclear stress test. Okay, the rate is fast here. It's about 120. So we have a tachycardia. Before you jump up and say this is sinus tachycardia, you need to look further to see if you see a P wave preceding each QRS complex. We see a P wave preceding each QRS complex, but at the same time you see another P wave what looks like similar to the one that was previously. So if you have 2 P waves for each QRS complex, then you need to begin to wonder about supraventricular tachycardia. If the rate is 120, the ventricular rate is 120 or 130, the atrial rate is about 240 to 260. So what fits into 260 atrial rate? You wonder about flutter. And if you look at here, this classic sawtooth appearance, and this is highly suspicious for atrial flutter with 2-to-1 conduction. When you have atrial flutter, since the flutter waves fall right on T waves, it is impossible to say if they have STT changes related to ischemia or infarction or for whatever reason. But the main thing is this is atrial flutter with 2-to-1 conduction, and we need to do further studies to first bring the rate down and look for any underlying pathology such as coronary artery disease or anything else that might be accounting for atrial flutter. This is a classic example of atrial flutter, so don't forget this picture. It's just like when you look at someone, you fix their picture in your mind. This is the atrial flutter picture. You need to fix this, the sawtooth appearance that we see here, and next time when you see something like this, you should instantaneously jump up and say that is atrial flutter with 2-to-1 conduction. Okay, we have a problem here. First of all, there is a first degree AV block. We have a right bundle branch block, and then we have little wide QRS complex in the lateral leads. So we have tall R waves in the anterior leads also. Plus in the inferior leads, we have STT changes. So what is going on in this electrocardiogram? This is say about 60-year-old person. We have some extra beats, PVCs or PACs. So we have a sinus rhythm with the first degree AV block, tall R waves anteriorly. You wonder about chronic lung disease with right ventricular hypertrophy, pulmonary hypertension, and also some increased voltage in the lateral leads. Is this a patient with hypertension along with some STT changes? So there are a lot of things going on in this electrocardiogram, and that should point you towards the right diagnosis when you sit down with the patient, examine, and put all the other reports together. Okay, here is a sinus rhythm. High anterior looks okay. Inferior leads, little flat T waves, and anterior leads, R wave progression is not great. Again, this may be related to lead placement. The lateral leads look okay. So basically, a normal electrocardiogram. Okay, here we have a sinus rhythm. We have an RSR prime, which is like an incomplete right bundle branch block, but we have an extra beat here, which is not in the same cycle. So this is an atrial premature beat. And look at the T wave. The T wave is much taller than the previous T wave. So this is suggestive of a P wave which is buried in part of the T wave. So we have a premature atrial complex, and we have a right bundle branch block along with poor R wave progression in the anteroseptal leads. This may suggest a patient with anterior infarction. So when you look at this electrocardiogram, it should immediately jump to your mind and say, oh, look at this. This may be a patient with anterior infarction with the right bundle branch block. Right bundle branch block is fairly common in patients with anterior myocardial infarction, along with some non-specific STT changes in the inferior leads. Moving right along, sinus rhythm, non-specific STT changes in the inferior leads. Same thing in 1 and AVL. And you come here, an RSR prime, which is incomplete right bundle branch block, again STT changes. This diffuse STT changes, incomplete right bundle branch block, perhaps left atrial enlargement. So this is a patient who needs a further evaluation with X-ray, ultrasound, and perhaps a stress test to see if there is any evidence for coronary artery disease. Right bundle branch block, sinus rhythm, left axis deviation, left anterior hemiblock, complete right bundle branch block, and non-specific T wave changes. So we have left anterior hemiblock, right bundle branch block, bifascicular block. So there are a lot of interesting findings in this electrocardiogram. But as I said, the moment you pull up an electrocardiogram, you need to start making diagnosis. You have to establish the rhythm, you establish the axis, you look at the regions, high anterior, inferior, anterior, and lateral. There are only four regions that you need to be focusing on, because these are the four major branches that we can deal with coronary angioplasty, percutaneous intervention, or coronary stent placement or bypass surgery. So that's how you practically approach a patient's existing medical problem. Sinus rhythm, not quite left axis deviation, but again, look at here, the STT changes. So that is abnormal. You come to the anterior leads, there's poor R wave progression between V1 and V2. There's flat T waves here. So this is a sinus rhythm with non-specific STT changes. Sinus rhythm, flat T waves throughout. So this is an abnormal electrocardiogram. No evidence of any infarctions, but the T waves are flat. So this is abnormal. Baseline artifacts, 60 cycle interference, sinus rhythm with perhaps some increased voltage in the lateral chest leads, non-specific STT changes. Okay, it looks like a sinus rhythm here. First degree AB blocks, the PR interval is 240 milliseconds. Again, low voltage in the lateral limb leads along with non-specific STT changes. So this is definitely an abnormal electrocardiogram with perhaps also left atrial enlargement. So sinus rhythm with, or you can even wonder if this is Wenckebach, but you need a long strip to find out, because short, long, and longer PR interval, and maybe a drop to QRS complex. Unless you have a rhythm strip, you cannot be certain as to what is happening. But nonetheless, first degree AB block, possible old anteroseptal myocardial infarction, non-specific STT changes. So there are a lot of abnormal findings in this electrocardiogram. Sinus rhythm, high anterior looks okay. Inferior, non-specific T wave changes. Anteriorly, lead, this may be mostly related to lead placement, because the rest of the electrocardiogram looks pretty benign. I would worry about lead placement, otherwise you have to call this as an anteroseptal myocardial infarction. Laterally, there are flat T wave changes. So this is sinus rhythm with non-specific STT changes and perhaps old anterior myocardial infarction. But I don't just go by that. I look at the whole patient, I look at the echocardiogram, look at the chest X-ray, and put all the pieces together to see if this patient had an anterior infarct. And here we have a negative deflection in lead 1 and ABL. This is the first electrocardiogram in this batch. We are seeing a negative deflection in lead 1 and ABL. Let's look at all the differential diagnosis for a negative deflection of QRS complex in lead 1 and ABL. It may be related to lead misplacement. If you misplace the right and left leads, you're going to find a negative deflection lead 1 in lead 1 and ABL. If a patient had a high anterior infarction, you're going to see a negative deflection in lead 1 and ABL. Can you think of any other condition where you may see a negative deflection? Think about it. If you had a right posterior hemiblock, you may get a negative deflection. I want you to go back, look at the textbook, and look at an example of a left posterior hemiblock. Okay, that's so much for the anterior leads. Along with that, there are some STT changes in the high anterior leads. Let's put this to the side. Let's move on to the next. Inferior leads, good R-wave progression, STT changes, suggestive of ischemia, left ventricular ischemia. Anteriorly, we got an RSR prime, which is incomplete right bundle branch block. Again, your PR interval is prolonged, which is 250 milliseconds. So we have a first degree AB block. We also have low voltage in the limb leads anteriorly. And laterally, we have some non-specific STT changes. So this is an abnormal electrocardiogram with possible high anterior myocardial infarction, along with first degree AB block, incomplete right bundle branch block, non-specific STT changes. As I said, all these findings have to be correlated with the patient's examination, chest x-ray, echocardiogram, and other tests to see how many of these are real and how many of these are just related to position or lead misplacement or anything like that. Okay, we got a sinus rhythm with left axis deviation, left anterior hemiblock, complete right bundle branch block, non-specific STT changes. You see anything else? Lead 1 and AVL look okay. And of course, we have a terminal slurred S wave, a classic case of a complete right bundle branch block. No evidence of any infarctions that we can really ascertain from this electrocardiogram. Okay, sinus rhythm, baseline artifacts. We can't really see the P waves, but the RR interval is pretty regular, and here we can see some good P waves. Sinus rhythm, non-specific STT changes, and nothing suggestive of any evidence of an old infarction. Okay, that's normal sinus rhythm with left axis deviation, left anterior hemiblock. There's Q waves suggestive of anteroseptal myocardial infarction, perhaps old, along with non-specific STT changes. So this is a sinus rhythm with left axis deviation, left anterior hemiblock, old anteroseptal myocardial infarction with non-specific STT changes in the infralateral leads. All right, sinus rhythm, left atrial enlargement, increased voltage criteria, ST depression suggestive ST depression suggestive of left ventricular ischemia. So this is a grossly abnormal electrocardiogram with a normal sinus rhythm, left atrial enlargement, increased voltage suggestive of left ventricular hypertrophy with subendocardial ischemia. So these are all the findings in this electrocardiogram, and this patient definitely needs to be worked up very aggressively. And this is a 33-year-old patient. That means I begin to wonder, is this a renal patient with hypertension, left ventricular hypertrophy, left ventricular failure, left atrial enlargement? Maybe perhaps this patient is on dialysis. So these are all the things that should start rolling in your mind based on the age, the sex, and the condition, and where the patient is. If the patient is in the ICU, you wonder if they had cardiac surgery, if they had pericardial effusion, things like that. Your mind should be going at 100 miles or maybe perhaps 1,000 miles per hour when you look at these electrocardiograms. Sinus rhythm, high anterior, little flat T waves, inferior leads look okay, anterior leads poor R wave progression. This may be just related to lead placement. There are some non-specific T wave changes. That's what I would recommend. So we have basically a sinus rhythm with lack of R wave progression in lead V1 and V2 with non-specific T wave changes. All right, moving right along. Sinus rhythm, high anterior looks okay, inferior leads look all right. There's a premature atrial complex, lack of R wave progression in V1 and V2, and some flat T wave changes. So the conclusion is normal sinus rhythm with a premature atrial complex with possible old anteroseptal myocardial infarction with non-specific STT changes. Sinus rhythm, high anterior looks okay, inferior leads look all right, anterior leads look all right, and the lateral leads look okay. Pass. Sinus rhythm, flat T waves, right away you can see, and there's a deep Q wave in just one lead, which is sort of isolated. It is not clear as to why we have this one, but nonetheless the STT segments are diffusely flattened. So you wonder what's going on with this patient. So sinus rhythm with STT changes suggestive of ischemia, something like that. All right, okay, this is rapid heartbeat. This rate is like 130. So are the RR intervals normal? No, they vary from RR from cycle to cycle, they vary. So I would say this is atrial fibrillation. Okay, let's look at atrial fibrillation. Just means this left atrial enlargement, and perhaps that's one of the equivalent criteria, but we need to look at all the rest of them like we are looking at a normal electrocardiogram. So 1 and AVL looks okay, inferior leads look all right, anterior leads good R-wave progression, lateral leads look okay. There are some non-specific STT changes, and STT changes are most commonly seen in patients with atrial fibrillation, especially with the rapid ventricular response, but nonetheless we are dealing with an abnormal electrocardiogram with atrial fibrillation, rapid ventricular response, and non-specific STT changes. Our primary treatment modality in this patient is to bring the heart rate down. It is 130 heart rate, you need to bring it to 70 or 80, then we look for any evidence of underlying ischemia or perhaps even infarction, something like that. So make sure when you look at atrial fibrillation at a rate of 130, 140, 150, the first and the most important criteria is to bring the ventricular rate down. Sinus rhythm, first degree AV block, QS complexes in 1 and AVL, possible old high anterior infarction. And again, we have loss of R-wave progressions anteriorly, so there could have been also anterior infarction. Inferior leads look okay, but they have STT changes to suggest they have ischemia. Lateral leads look okay, so this could be a patient with a proximal LAD lesion involving the diagonal bench that might have resulted in an infarct involving area lead 1, AVL, V1 to V3. I'm just guessing, but nonetheless, we have also some evidence of an incomplete right bundle branch block. So this is an abnormal electrocardiogram with possible high anterior infarction with non-specific STT changes diffusely suggestive of ischemic heart disease. Okay, this is a sinus rhythm. High anterior looks okay, inferior leads all right, anterior leads okay, lateral leads okay. Basically, I think most of the things look all right except for some minor T-wave changes. Next, this is a pacemaker rhythm. See, how do you know this is pacemaker rhythm? Well, look at the spikes here. They are regular. The rate is about 60. When you see spikes with wide QRS complex in every lead, that's pacemaker rhythm. I mean, that's our first and final diagnosis. Beyond that, we can't interpret very much unless we see some other underlying rhythm which may give us some clue as to what is happening with this patient. So this is a tachycardia. Is this sinus tachycardia? There's an extra beat here. Yes, this is sinus tachycardia. We see P waves, regular P waves here. There's a premature atrial complex. The rate is 100, and 1 and AVL are okay. Inferior leads more or less all right. This poor R-wave progression anteriorly, so we have a sinus tachycardia with a premature atrial complexes with perhaps maybe an old anterior infarction with non-specific T-wave changes. All right, we got a sinus rhythm. 1 AVL looks okay. Inferior leads, low voltage, but nothing significant. Loss of R-wave progressions in the anterior leads and non-specific T-wave changes in the lateral leads. So this is sort of a borderline electrocardiogram. Sinus rhythm. High anterior looks okay, inferior wall looks all right, anterior wall looks okay, and the lateral wall looks okay. So let's call this a normal electrocardiogram. Here's the next electrocardiogram. Sinus rhythm, 1 AVL looks okay, inferior leads, 2-3 AVF all right, anterior leads, left atrial enlargement, little poor R-wave progression, but the rest of the electrocardiogram looks normal. So I had to just say sinus rhythm with left atrial enlargement with possible lack of R-wave progression in the anterior leads, which may be related to lead placement. Sinus rhythm, high anterior looks okay, inferior looks okay, lateral wall looks anterior wall looks okay, and the lateral wall pretty much normal electrocardiogram. This is our final electrocardiogram with what looks like atrial fibrillation because you can see some atrial waves, but the rate is pretty fast, almost 3 to 350. And we also have 1 AVL looks okay, inferior R-wave progression is good, anterior wall R-wave progression is okay, lateral wall is okay. So this is basically just a sort of underlying atrial fibrillation with some non-specific STT changes, but nothing really significant acute happening other than the atrial fibrillation. Ladies and gentlemen, that concludes our electrocardiogram, and we have pretty much covered close to 100 electrocardiograms in this short period. This is rapid EKG interpretation. I am Dr. NIK NIKAM. Hope you have learned something from this. I would suggest you take a notebook and go back and listen to this at least 1 to 2 more times. Then make note of everything new that you learn from each electrocardiogram. When you put all these new findings and fix those images of the electrocardiogram when you are working in the emergency room, in the operating room, or if you are working in the ICU. The moment you look at those electrocardiograms, you should be able to instantaneously figure out what is happening on the electrocardiogram at least. Then you correlate that with what's happening at bedside, then you will be able to put all the pieces of the puzzles together. That's what I've been doing for 35 years, and I enjoy what I do. Have a wonderful day. Thank you.